The purpose of this session is to talk through a case study example for metastatic spinal cord compression. Metastatic spinal cord compression occurs where there is pathological vertebral collapse or direct tumour growth causing compression of the spinal cord, which may result in irreversible neurological damage and possible paralysis. It is therefore classed as an oncological emergency. Around 85 to 90% of metastatic spinal cord compression occurs from extradural tumours. The other 10 to 15% are intradural, either intramedullary or intradural extramedullary tumours. Case study 4 is a 57-year-old female who had an undisclosed and untreated breast cancer for around 4 years and was now under the care of oncology and currently on hormone treatment. She was reluctant generally to engage with medical services. A recent CT thorax abdo-pelvis showed extensive malignant disease in both breasts with chest wall involvement, marked right pleural effusions with features of pleural metastases, widespread lymphadenopathy, and extensive bony metastatic disease. She'd been admitted to a hospice with pain in her lower back, which was radiating into her buttocks, thighs, and knees. She had a 2-week history of reduced mobility, and power was 3 out of 5 in bilateral lower limbs on admission, with some improvement following steroids. That was given as a 16 milligram stat dose initially on that presentation. She had no bladder or bowel changes, and sensation and reflexes were intact. A whole spine MRI was ordered by the hospice and completed the day prior to them referring to the MSCC coordinator. So at the point of presentation to the MSCC pathway, the MRI was complete and had already been reported to show spinal cord compression. So that the MRI was reported to show diffuse metastatic disease throughout the spine, with moderate wedging of T8 and marked wedging of T9 vertebral bodies, with moderate wedging of T12. There was some retropulsion and convexity of the posterior part of the body of T9 into the spinal canal, with abutment and mild compression of the spinal cord at that level. And there was also some encroachment on the spinal canal at the level of T11 with moderate to marked canal stenosis. So that essentially means that there's 2 levels of spinal cord compression. So the initial management plan was she'd had the 16 milligram stat dose of dexamethasone, and we're advised that they continue with 8 milligrams BD of steroids whilst we put a treatment plan in place due to her lower limb neurology. She was on bed rest to await remobilisation by the physio team following treatment, and the reason for bed rest in this case is she had leg weakness and was therefore a falls risk, so remobilisation needed to be controlled and appropriate. She had pain on mobilising, so she was more comfortable on bed rest, and her SINS score was 12, which suggested her spine was potentially unstable and may need consideration of a spinal orthosis for pain management, and analgesia needed to be optimised. This patient was not considered a candidate for surgical consideration. Reasons for that included the fact that there was extensive spinal malignancy from a spinal surgical perspective, spinal stabilisation would not really have been feasible, and also patient choice. So the patient didn't want invasive management for any part of her disease. So radiotherapy was offered, and the patient agreed to attend for radiotherapy the following day. So in terms of radiotherapy management, an 8-gray single fraction given in 1 day is appropriate for a large proportion of patients with a spinal cord compression. It's also indicated for people with spinal metastases without cord compression who have non-mechanical spinal pain. And it's generally an 8-gray single fraction is used where there's for anybody who doesn't have a high risk of side effects. So as long as a reasonably small volume of radiotherapy is indicated, and the patient hasn't had previous radiotherapy to that site to a certain dose. So 8-gray single fraction was appropriate in this case. The patient needed transferring from their hospice over to Clatterbridge Cancer Centre, Liverpool, and in this case it was over a weekend. So there's no planned ambulance over a weekend, so it needed to be a Category 2 emergency ambulance transfer. And the reason it needs to be an emergency transfer is there's a limited time of the day where radiotherapy can be given, and we needed to ensure that this patient had their treatment within 24 hours of diagnosis where possible. So it's arranged as an emergency transfer to the hospital. On arrival, the patient has a clinical assessment and consent, and the consent is often centred around obviously the treatment that's going to be given, but the possible outcomes from that treatment as well are really important. So for somebody with a spinal cord compression and neurological deficit, it may be that the radiotherapy isn't going to reverse that deficit. So it's important that when the consultant is consenting, they're explaining that the weakness that they have now may not improve, but the aim of the treatment is to prevent further deterioration and manage the pain as well, if that's part of the indication for radiotherapy. The radiotherapy is then planned by over the weekend an on-call therapeutic radiographer team. The radiotherapy is created in the background, so that's computer planned to that patient's anatomy with the correct dose calculated. An EHA is sometimes offered for patients in this pathway where they're not acutely under another team who are already offering that service. And then the radiotherapy treatment is given again over a weekend. It's by an on-call therapeutic radiographer team. And the patient is then repatriated to the hospice on an emergency ambulance, which is a little bit more challenging on return because the intervention has been provided. The transfer back is for ongoing care rather than emergency management, so it can sometimes be a little bit delayed. So that's what happened in this particular patient's case. They were transferred across, had the radiotherapy, and then were transferred back to the hospice on the same day. So when radiotherapy is given for spinal cord compression, quite often the vertebral level of the spinal cord compression is treated with a vertebra above and a vertebra below, but this sometimes depends on the extent of disease within the other vertebra close by. This patient had extensive metastatic disease throughout, and it's not possible to treat all of the vertebra. The indication is for the symptoms of cord compression to try and reduce or stop any further progression of the symptoms, and also to manage pain. So in this case, the T9 to L1 vertebra were included within the treatment field, and that was to encompass the 2 levels of compression with vertebra above and below. Steroids were indicated because the patient had neurology before presenting with a cord compression, and also alongside the radiotherapy, we give steroids to try and manage some of the side effects of the radiotherapy that can include inflammation and pain flare. So the steroids were given on a weaning dose regime. So they were currently on 8 milligrams BD, and these are normally, as a standard protocol, halved every other day to reduce them to stop within a week of radiotherapy treatment unless otherwise medically indicated. So for some people, steroids are part of their ongoing pain management plan or symptom management plan, depending on the extent of their disease. In this case, ondansetron was required as an anti-sickness medication before treatment, and that's normally guided by the level of the treatment field. So because T9 to L1 may encompass the stomach and some of the small bowels within the exit dose of the radiation field, anti-sickness is generally advised. Analgesia was required for this patient when transferring, so any movement of the patient across was causing an exacerbation of pain. So analgesia was timed to try and optimize it for any points of transfer for this patient which was exacerbating her symptoms. So in terms of transfer for her, we had the ambulance transfer from the hospice over to Clatterbridge initially. The patient was then transferred from the ward at Clatterbridge down to the radiotherapy planning department, where they required a PAT slide across to the CT scanner couch and back. They were also transferred from the ward down to radiotherapy treatment in a similar process, which required moving the patient, and then also back from Clatterbridge to the hospice on an ambulance transfer. So it's important to think about the timing of analgesia to try and optimize it for those points where pain is more likely to be exacerbated. So following radiotherapy, the patient will be given a copy of their consent form, an information leaflet and an alert card on MSCC and signs and symptoms. So although they've presented with cord compression, the risk for patients who've had a cord compression is a future progression of the cord compression or also another cord compression at a different level, which may present with slightly different signs and symptoms. So it's important that they have a good understanding and then they can alert somebody early to any new signs or symptoms. And also a copy of the number for hotline, so that if they are discharged from their current place of care, they have a point of emergency contact should they not know what to do with any treatment side effects or any new signs or symptoms. Post-radiotherapy documents are sent with the patient on repatriation to advise the clinical team looking after them regarding what the patient's been told, the area that's been treated, including any potential side effects, guidance on steroid weaning, advice to refer to the palliative care team if they haven't already. In this case, they were obviously in a hospice. Guidance to review analgesia, and mobilisation advice, including graduated sit-up and remobilisation, and advice to include the therapies team, so physiotherapy and occupational therapy, in that remobilisation and assessment process. The MSCC coordinator will then contact the primary oncologist to advise that the patient's been treated through the pathway, and then they will arrange follow-up appointments with the primary oncology team to review ongoing oncology management.